name is Jenny Maylert, and I am a veteran who became a teacher at Eastern Washington University. I started as an adjunct, and eventually they gave me a full-time job, maybe because I just wouldn't go away. But I loved my job teaching, but because of my head injury, I found that I had to quit teaching. And that's, for me, tragic, because I enjoyed teaching so much. The personal one-on-one. Oh, it's not coming through. There we go. Okay, is that better? There we go. Okay. When I fell and hit my head, it had nothing to do with the military. I was already a veteran, and I was teaching at the university. I've told people this many times. In fact, I've already mentioned it to a couple of you here tonight. I was lucky enough, I suppose it's lucky, that when I fell, I was 7 blocks from Harborview. And at the time, my department chair was Mr. John Anderson, Dr. John Anderson, who's here tonight and part of this symposium. Why is that important? Because John is a TBI expert, and he was my boss, and he bent over backwards to accommodate me for as long as possible. And I tried teaching for a couple, 3 years after my accident, but spacing my classes out, teaching classes, for in classes that should have been taught 5 days a week, we tried to do in 2 days, and instead trying to make my schedule easier for me. We did all sorts of things, but in the end, I ended up having to stop teaching. And so I know the difficulties. And I'm ever so grateful to not just John, but all of the instructors and all of the professors who tried to help me, and the veterans at Eastern who reached out to me. And so therefore, I'm grateful that tonight I was asked, even though it's in a pinch, to be the moderator tonight. We have some veterans who are going to be on the panel tonight. We're going to ask each one of them to tell a little bit about themselves as well. Right? So we'll start. Each one start. It doesn't matter which end we start at. So we begin right here.
Do I need this or use this? Oh, okay. Can you hear me? My name is Andrew Raleigh. I'm a veteran of the U.S. Army twice over. I joined in 1997, and I served 4 years, including a tour in Bosnia. And I got out in the spring of 2001. And then there was some stuff that happened in the fall, so I re-enlisted in the fall of 2001. And in 2003, I was with the 4th Infantry Division in Iraq, and I left the Army again in 2005. And I was finally ready to go to college then, and so I went to Spokane Falls Community College and Eastern Washington University, where Dr. Anderson was one of my instructors. And then I went. I worked at Sacred Heart in the inpatient child psychiatry unit and the adult unit, and some time in the ER. And then I went back to Eastern for my master's degree in psychology, where Dr. Anderson was my advisor for my thesis. So. And it was during my time in graduate school that I began working with veterans at the Spokane Vet Center. And I loved the work. And when I finished grad school, I stayed on as a volunteer at the Vet Center. I figured it was better than paying to go there for credits. So I stayed on as a volunteer therapist while I was working at Providence Sacred Heart, and I eventually was approached and asked if I would take a position at the Vet Center, and I took that position in 2012, and I've been there ever since. I've worked with rural veterans out in Okanagan County mostly, but also North Idaho, Western Montana, down into central Idaho. We have a pretty big area that we serve our vets in. And I've been there since 2012, I said that. I've had veterans that I've helped who have had traumatic brain injuries, and I'm not a physician, not a medical specialist, but there are certain things that psychology can do for those affected by TBIs. And I think that's probably enough for me.
Thank you. Thank you. Would you like to go next?
Oh, sure. Hi, my name is Rick Perry. I'm a physician specializing in physical medicine and rehabilitation, and I've worked with veterans at the VA for over 10 years, the past 4 here at the Spokane VA. And among the many populations that I get to serve, like I work on our rehab unit in our little skilled nursing facility area, and also help out veterans in hospice, and a whole bunch of veterans with MS and ALS and strokes and spinal cord injury. But the most enjoyable work that I've done is serving the veterans who've had head injuries and been exposed to concussive blasts as they come back from service. I'm part of a team. I'm the physician on the team with a neuropsychologist and 2 nurses that get to meet these veterans when they're ready to enroll in the VA or whenever they identify that they've had a head injury. And in addition to seeing the ones coming back, I also get to see any veterans in clinic that have had brain injuries outside of their service that have concerns or questions. And it's a really exciting time for my work, because the VA has made available all sorts of additional supports and helps and resources, both within the VA and also in the community, that make serving veterans with TBI and with the complicated history that comes with having a TBI and being a veteran, all these supports make it really, really rewarding. And I just really, I love it. And I just feel privileged to be a part of the recovery for veterans that are trying so hard to make sense of their life after service, after injury, and to improve. And it's again, just a very privileged, and I'm glad to be invited here. Thank you.
Hello, my name is Alicia Hagee. Can you hear me okay? I'm a neuropsychologist, and I work at St. Luke's. Thank you so much. Yeah. I work at St. Luke's Rehabilitation. I've been there since 2017, where I work primarily with patients with brain injury and spinal cord injury. I was an Air Force veteran, so his boot camp beat most of my service time. I served from 2011 to 2015, and I did not deploy. I ran the mental health clinic in Las Vegas, so you can imagine I've got stories for days. 19-year-olds in Las Vegas, you can fill in the blanks from there. While I was serving, I had the opportunity from my position to do a lot of work with service members, either coming back with or acquiring brain injury, testing, supporting whether it be some anxiety, some PTSD, helping facilitate the individual adjustment, but also family adjustment, and trying to help individuals thrive, whether they were staying in or transitioning out to civilian life. And once I got out in 2015, I went and specialized in neuropsychology in California, and then ended up here. And I love the work that I get to do. I still have a great deal of enormous respect and passion for veterans and those who serve our country. I'm also supporting people in the community and trying to help people thrive and live their best possible life.
My name is Frank Jackson. I'm a physical medicine and rehabilitation physician as well. I trained at the University of Utah and there had the opportunity to work with a number of veterans in a clinic very similar to what Dr. Perry was referring to. Currently, I am the brain injury medical director at St. Luke's here in Spokane. Mainly, currently my experience is working with veterans that after their service have had brain injuries, as well as veterans who have had strokes and other neurologic insults.
My name is Heather Boehm. I'm the Eastern Washington outreach, TBI outreach for Washington Department of Veterans Affairs. So it'd be your state VA. We have federal VA here. So I'm actually a U.S. Army veteran. I enlisted in 1992. I discharged in 2014. So after 22 years of service as a combat, was a combat engineer for almost all that time. And then the last 6 years I was transportation specialist. I met my husband obviously in the Army. We have 5 children together. But my husband is a TBI survivor. In his first deployment in 2003, he was, his convoy was struck by an IED. And the windshield, it actually struck the vehicle in front, and his windshield exploded. And he was exposed to a concussive blast. Being that it was 2003, the diagnosis for TBI wasn't actually at the forefront. And he still deployed a second time. During our second deployment, I found out I was pregnant with my son, and I was sent home, so my husband stayed in country while I came back and was on duty here. The funny thing is my husband played semi-pro football up to and rugby prior to even enlisting in the military. So he was already exposed to TBI, and then 9/11 happened, so that caused him to then enlist in the military. Never once had we ever considered that traumatic brain injury was ever part of the issues that he was having and assimilating with his job. Funny thing is I started working for WDVA in 2011, but and I discharged in 2014, and I saw firsthand how we were letting down our service members when they would come back in looking for help, and we were then we were doomed to make our same mistakes again because they were ultimately not doing anything. So I decided to not be part of the problem and be part of the solution, and started transitioning out of the military. So I dropped my retirement papers. My husband was then medically discharged. So that meant that I had to stay a little bit longer because I had to stay in to make that 20-year mark since the light was already at the end of that tunnel. I wasn't going to walk away that easy. It took them 2 years to discharge me. I guess they thought I was worth holding on to. Who knows why, right? Ultimately, now I'm fortunate enough, I work 2 programs here in Eastern Washington. I'm from Spokane, so I was able to come back. My husband's from Leavenworth. So I get to serve the veterans that are in my own community. So with the 2 programs, I work at all the community colleges, all of our universities here in Eastern Washington. I have a navigator that helps transition those veterans, as well as the TBI outreach. So I'm fortunate enough that I get to come in contact with veterans on an everyday basis. So I cover all of Eastern Washington, anything this side of Snoqualmie, all the way to Oregon, all the way to Idaho, all the way to Canada, to include expats that come in that are living in Canada that still need services. So I get to see them from college after they've come back, and I get to see them at all walks of life. And the interesting thing I don't think people understand is for WDVA, you don't have to have incurred your injury while in service. You could have been in a car accident 10 years after discharge, and there's resources still, where sometimes federal VA is kind of dependent on your service connection. So that's the kind of that extra layer of resources that I don't think Eastern Washington knows about. So that's me.
Thank you. Thank you, everybody, for being here tonight. The general topic that we're going to be discussing tonight, a general question is, what are the medical, psychological, and social issues for veterans and service members living with a traumatic brain injury? This includes, but is not limited to, health-related recovery trajectories, long-term physical and psychological health conditions in persons with TBI, community social reintegration, and the rehabilitation needs that includes access to support services. Furthermore, we would like the panel to touch on the following overarching questions. Okay. Number one, we'll start. What are the primary issues seen among veterans and service members living with a TBI? Is there anybody who'd like to start? The primary issues seen among veterans and service members living with a TBI.
So firsthand, I mean, obviously I see veterans, I get contacted all the time, either in the college session, for one, they'll start attending school, obviously, because they have GI Bill. And everything seems to be going really well, but the reality is all of a sudden the wheels of the bus are kind of flying off. And they don't know why. And some of it is memory, and then it's just the lack of services or the lack of understanding and education of what a traumatic brain injury could be and how they could have acquired it while in service, because that's not something that was really talked about. Maybe in the last 3 years, we really do talk about it a little bit more than we did previously. So that seems to be kind of the lack of education. So we have been providing services to the universities and community colleges to better serve those veterans that they're coming in contact with, but as well as educating the veterans as to some of the things they might have been exposed to and what could have happened and where to go look for, where they need to look for those resources and services, as well as within the community. Because sometimes they'll go in and they've been treated and things just aren't getting any better. So sometimes they're looking for something different. So we get phone calls all the time asking for other resources that might help. And then finding out that maybe it was related to TBI is kind of having to peel back that many layers of that onion. Because sometimes that's not where we first start. That's something, we are learning to ask those questions up front now rather than at the very end. But still sometimes it's just that education piece, I think, for us.
I would agree. The most common presentation in our clinic is that a veteran has identified that they're having trouble with focus, concentration, and especially short-term memory. It just giving numerous examples of how they're talking with their spouse and have a little conversation and then can't recall a short time later that they were talking about anything, or simple things like being able to go to the store, and they used to have a perfect memory, but then they get there and can't remember at all what's happening. And so that as far as like the primary focus, it always seems to be centered around those things. And I agree that the most important component that really makes a difference is education and understanding. And one of the things that is unique to veterans with brain injury is that brain injury didn't just happen, usually anyway, didn't happen as part of a sports competition or falling down an icy set of stairs. The vast majority of the veterans that we see in clinic had this exposure in the middle of a battlefield, and there's on top of the concussive or the actual brain injury itself is a whole series of intensities, sometimes attached to indescribable outcomes, as far as losing fellow soldiers in the event, and so that component, that component of the environment and what's happening at the time of the injury is as important as the injury itself. And so we talk about we talk about the story and the circumstance, and also talk about currently how two key issues that affect focus and concentration are working for the veteran in their life. And those issues are, one, sleep, which in the vast majority of people in clinic is dramatically altered. And the other one is chronic pain. It's not like you survive an entire, series of deployments and come out of it without a constant pain that, that you've been living with this entire time, and ignoring but not realizing the impact that those two things can have on focus, concentration, and memory, in addition to the trauma of the event surrounding the brain injury itself. And I just want to note that sometimes there is trauma because an injury has been ignored or dismissed by several, several, whether it's commanders or people, medics in the field that know the importance of keeping that person operating. There's this additional kind of psychological trauma of just not acknowledging that injury that compounds everything else I mentioned. But so it's really important to be able to hear the story, and then to point to just different options and supports that might help.
And I think there are two cultural factors that can impact a veteran's experience of traumatic brain injury and that spectrum of traumatic brain injuries, whether the injury was incurred in service or after service. And part of that is the mindset of a veteran is mission focused. An injury that was incurred in the line of duty, very often people aren't raising their hand and saying something's wrong. They are begging to get back out there because what they want to do is support the other people that are there, and they want to stick with the mission, and they are willing to ignore or compensate or override anything else that may be going on because they are so mission focused. And I think that mentality follows even after you separate, and someone who's had an injury may be really likely to dismiss what's going on, think that it's nothing, and try to problem solve around or find another way to do what they're trying to do. And so ironically, I think that incredible dedication and service-mindedness can lead us to creating habits that actually reinforce or keep us from getting access to some of these services. And just raising that awareness and encouraging people to at least ask the question. If something is going on, if there's a barrier to living your best life, whether you can identify what happened or not, asking the question and seeing if there isn't something that can be done to help. And the other piece to keep in mind is when there's something that happens, when there's a bomb blast, when there's a fall down icy stairs, I think it's easier to think about traumatic brain injury. What's trickier is that small traumatic brain injuries, concussions, can kind of be additive over time. So something happens at the time, you had a fall in basic, you hit your head, you felt a little dazed, but you got back to it and you were okay. Over time, multiple incidents like that, and then getting exposed to something a little bit more significant, can lead to a little bit more difficulty than you might expect from the incident in and of itself. So being mindful that the life that veterans live is sometimes a little bit more a little bit more exposure than other people might experience. And so again, encouraging people to ask questions, to be curious about how they're functioning and what might be contributing to that. Seeking out services, seeking out evaluations, seeking out resources to get what they need to really be their best.
And thinking about how all of these kind of complex factors interplay upon one another creates, I think, this spiral that becomes very difficult down the line to detangle. From the initial injury to the stress incurred to all of the mental health issues that might be going on as well, musculoskeletal, and then really trying to pull that out, it can be very tough for a service member down the road. So,
I think another issue is the differential diagnosis. Mm-hmm. I think there's a lot of comorbidity, like you were talking about with post-traumatic stress, but also not always. And I think there's a tendency to overdiagnose post-traumatic stress. And I think it's important to remember individual differences. And just because that veteran endured that brain insult, it may not be as psychologically effective on that particular veteran as we may be thinking. And so a lot of what we're seeing now is we're treating post-traumatic stress instead of a traumatic brain injury. And a lot of that has to do with a lot of what's going on inside the VA system right now. And it's a little frustrating working on the inside of that system, trying to promote healing, but being told that you have to focus on this when really you want to refer them for a battery of testing for a traumatic brain injury, but the focus is elsewhere because there's this assumption that because that veteran went to war, they automatically have post-traumatic stress disorder. But sometimes it's more likely that they have a traumatic brain injury, and we're missing that a lot of the time.
Well, I think that lack of education piece was key for us. Is, it was easy to say my husband had post-traumatic stress. And, we spent 8 years figuring out what post-traumatic stress looked like and getting better, thinking, oh, you should be better. When in actuality, he was getting better for that, but his coping skills for his traumatic brain injury were failing. So never once were the questions ever asked, even though they'd heard, we still treat for post-traumatic stress. But I see veterans firsthand, and the reason they show up in my door is because of their coping skills. At this point, our coping skills are failing, and so then all of a sudden we start asking those other questions. They're like, oh, I have post-traumatic stress. And I'm like, oh, so, we start asking some other questions because, we do see some mirroring of a lot of the same things, and asking that story and say, have you ever heard of a traumatic brain injury? And they're like, never thought about that. I had a concussion when I was a kid. And then you say, you start talking about their other, and they're like, oh, wow. I think that makes sense. And that's what happened for us, is like the light came on. Like he could not figure out, like we had to count kids. Seriously, who thinks about that? But literally when you have 5, he had to get in the car and he had to make sure that they all counted off so that he didn't drive away and leave one of them. Because something so simple became such an enormous problem for him to remember. So I think that I think you're right. I think that treatment of post-traumatic stress actually made the TBI kind of stand out a little bit for us, but it took us 8 years to figure out what it looked like.
Caveat, keeping in mind that a lot of those
Yeah.
occurrences where the brain insult happens, those are what we call a potentially traumatic event, and it a lot of times does result in post-traumatic stress comorbid with the TBI. And so you got to figure out which one do you treat first. Do you treat at the same time? And then in some cases, the TBI wasn't even recognized until the PTS was treated. So they're comorbid, sometimes not, and sometimes the treatment of one can help the other.
The one thing that I think, wouldn't you agree, is like one veteran is not like any other veteran, is like every other veteran. The fact of the matter is what works for you isn't going to work for me or isn't going to work for you. And that's the thing, is we get very comfortable at having the same solution for the same problem, but these are solutions that are different for every single person, depending on the situation. And those are the things that I noticed that we've had to really change. I mean, it's constantly an evolution for us, and that education we have to continue, making that informed, piece, so that the information gets into the hand of the veteran in the fewest number of steps.
The encouraging thing being that a lot of those comorbidities, whether it be sleep or other things that we know are clouding, muddying the pool and are overlapped in a lot of these diagnoses, are things that if we can get the person to identify it as a problem, we can do something to help. And if we're targeting some of those lower hanging fruit, sometimes it's easier to clear things up and start to identify what really is causing the difficulties and then target that more effectively.
Yeah. All right, moving on. Thank you very much. Very good start to our symposium. This next question, when I first looked at it, I was a little bit confused because I thought maybe it sounded too much like the first one. But then I got to thinking about it, and I think I have an example from my own life that will show you a little bit about how to answer it. And I'm glad because we have so many therapists here. They can I'm sure, contribute to this answer. But the question I'm asking next is, what are the potential challenges for veterans and service members in rehabilitation? Now, that's I thought at first that it sounded similar to the first question. What are the primary issues? But now I'm asking, what are the challenges in rehab? And my example for me, when I went to speech therapy after my accident, I discovered cognitive deficits that I didn't realize that I had. in following directions, for example, and things like that. And those were things that I had to come to grips with. I understood I had pain. Everybody has pain when they have a head injury. But I didn't realize the extent of some of the cognitive deficits that I was experiencing. And I had to accept that I had those deficits. I had to learn to deal with those deficits. And so that's my example of the potential challenges for service members in rehab. And that's my question next to the panel. What challenges do you think potentially that veterans will experience in rehab?
I
We
would
have a
like
whole
to
panel
kick
full.
that one off, if you don't mind.
No, absolutely.
It's psychological rehab, but, so I think I forgot to mention this in my intro. I'm a readjustment counseling therapist at the Spokane Vet Center, and our primary function is to take war veterans and help them readjust to life post-war. And so I guess to compare that to a civilian population, it would be adjustment disorder in a civilian population would be readjustment issues in our population. And it can be difficult for a war veteran to come home and adjust from that culture to a culture that you're not fighting for the person next to you's life on a daily basis. And so they have that culture shock to deal with. But then on top of it, they have issues, and some of my patients I've seen, chronic headaches, memory concerns, and depression, which comes along from the physical, the chronic pain and the memory deficits, and their inability to readjust at the pace that they think they should be, or maybe they came home at the same time as their buddy, and their buddy is readjusting faster. Well, he didn't suffer a TBI. And so they've got all these other factors to play with. The memory is a big one for a lot of the veterans that I've worked with TBI. And the chronic headaches are probably the most prevalent.
And when you think about rehabilitation in terms of physical rehabilitation and occupational therapy and speech, I think in some ways that individual focus is a challenge in and of itself. Whether it's someone, again, who was injured in service or someone who was injured afterwards, it can be uncomfortable to spend all day long with somebody paying attention just to you. You don't have those people around you to lean on and to support you and for you to support them. But depending on how severe the injury was, you've also got people completely in your space teaching you how you're going to pee, when you're going to use the restroom, how you're going to do dressing and bathing. And for someone who may have some anxiety, some comorbid anxiety, that can add a whole nother layer on top of the challenges of rehabilitation. So that building of that trust and that giving people as much choice as we can and predictability, and encouraging patients to advocate for themselves, to speak up when something is getting overwhelming or something is triggering something else or is causing a particular challenge, I think is huge in terms of helping them be successful, be more self-aware, and progress through and get the most out of their therapies.
I would, I agree. I mean, just being able to acknowledge, there's something so beautiful and powerful and healing when a person has been struggling with a set of challenges or symptoms and finally has a name for it, so they can say, yes, that, I have this, this condition or this challenge, and then speak it aloud and be able to ask for the help that's needed. From my perspective, the very biggest barrier to rehabilitation in brain injury for the veterans that I see is just time. I mean, these are young people in the prime of their life. They're looking for careers. They have young families to take care of. They have so many demands on their person that even with a really great connection and interaction, looking at the injury and all the possibilities of supports for it, everything has to fit into a real life schedule. And so all you can do is allow for that. I mean, Yeah, so many times I say to a veteran, we just want to take over your life and keep you here in the clinic, 24/7, to make you better. But that's not doable. It requires, it just requires integration with a person's real life, and that's the challenge I see, because there's plenty of great supports, but working through those supports while you're trying to go to school or keeping a job. Is a real challenge.
And for me, seeing patients typically a little bit farther down the road after they've been out of the service and now have maybe incurred a head injury for whatever reason, dealing with some of the lifestyle issues that have kind of been generated down the road that are a result of their deployment and some of the stress that's accumulated over the years. That with this population, like Dr. Heggie said earlier, that it can be very difficult for them to advocate for themselves. And on the inpatient environment, trying to ask a patient about what's bothering them and how their sleep is and how their pain is, and patients just being wanting to be strong and not want to tell me and wanting to work through it. It's very challenging for them, I think, and it's nice when I'm finally able to form a bond with a patient and they're able to feel open to me so we can finally have that dialogue so we can start addressing some of these issues and really make some breakthroughs.
And I think for us, like I come from a this is my life kind of thing, and you've got a panel full of clinicians here, which is very rare that you get to have so many subject matter experts. And for me, I come from it, because this is something that we live every day. I mean, with our kids, we actually have a child that has SPD, which is sensory processing disorder. And for us, sending my husband to the VA was something that was overly stressful, like beyond stressful, to the point of he'd get to the door and he would melt down at the door and he'd get back in his car. So my son had to go to speech and OT ever since he was 18 months. And he was nonverbal till he was 4. So going to therapy for our son was something we did all the time. So I had to get really creative, and this sounds like at the most basic sense, but I would send him to therapy with our son. Now, did he realize that I was actually sending him to therapy for himself? He had no idea, which, is kind of, I guess, a spouse's prerogative to kind of manipulate their spouse. And I did, but the reality is I think I saw it. The light for me came on that it was making him better, because whatever they were doing for our son was giving him therapy. And if that was the least stressful way for him to get it in the most basic sense, I was willing to, facilitate that. And if I had to lie, I had to lie. Say, oh, I can't go today, so I'd send him. He would go in. They would actually, I told them to, normally I would sit in the lobby, but they would have him come in and get on the floor and do these therapies. And it was something so basic that we saw this improvement, that he could then go into the VA and seek treatment, or go to the vet center and seek some treatment, because the anxiety level had come down, because he'd kind of gotten a little bit better and he actually could advocate for himself. And the one thing that I empower veterans to do is the only person that's going to advocate for them is going to be them. If that means that I have to even write down what he needs to ask the doctor because he gets confused when he gets in, or they get him off track, and he only gets 3 things on that list, but that's 3 things more than he had the day before. So, the thing is, if we had more clinicians that were like these 4 that would ask some of these questions that we haven't been able to ask, I think that we've seen this evolution. It wasn't like this before. Before 2005, they weren't asking any of these questions that these folks are asking. So this is just this evolution that has come forward, and it just changes every time we go into the VA, or we go into St. Luke's, or we go to the vet center. The fact of the matter is a lot of our veterans in our community see community people that don't necessarily go into our VA hospital. For one, it's a smaller venue, so they do have to come out into the community, and they find trust with these folks. So my hats off to you guys.
Another piece to remember is that treatment doesn't always have to look the same. No. So somebody may not be willing to go see a mental health counselor, but there's actually a robust body of evidence growing that you can treat comorbid PTSD and TBI with following an exercise plan and yoga. that you can recalibrate your nervous system, and that having that routine, staying physically active, will improve the symptoms of both. But if we're honest, we need to also keep in mind some lifestyle factors that can be a little bit more common with veterans. So whether that's energy drinks all day to keep themselves awake, alcohol to fall asleep at night, some of those things can be compounding things too. So when we think about challenges to rehabilitation, helping people just in general get healthy, get that motivation to be in their best place, I think can also be a challenge.
And it's anecdotal, but the evidence that we've seen at the Spokane Vet Center anyway, with these alternative therapies you're talking about, yoga, we have a yoga group, and in the summer that yoga group meets in the park across the street from our office. We will do one-on-one talk therapy sitting in a room across from you in a chair and a couch, and that's fine. We do that, but we also do the yoga. We have a healing garden out back. The property manager that we lease from donated a piece of land until someone else leases that. We have a healing garden back there. Personally, I work with a group called Project Healing Waters, a national organization, it's a nonprofit. They do fly tying and fly fishing. They come in weekly, actually twice weekly in our office, and I know Tuesdays they're up at the VA hospital as well. And some of these alternative activity therapies, we do art therapy. I could just keep going.
You may, because the next question is actually, how can veterans and service members best manage the complex cognitive and emotional issues associated with TBI? And these are some alternatives that you're suggesting.
Yes, I would say that the best way to manage those challenges is to get active. And it was best explained to me by my boss a few years ago. I had a patient that I was sitting with for a talk therapy session, and we were finishing our session, and he looks at me and he says, I got my fly rod out in the truck. We should go fly fishing. And it dawned on me that I'd gotten away with some alternative, non-traditional stuff already. So I said, sure. I booked a 3-hour session for the next week with him, and we were going to, because we're right next to the river, and so we were going to go fly fishing on the river for our session, because he saw my fly rod in the corner of my office. And so I thought about it after he left that day. I went to my boss, and I said, you know, I know that it's better to ask for forgiveness than permission sometimes, but I may need to ask for forgiveness. I just booked a 3-hour session to go fly fishing next week with my veteran. I didn't realize it, but at the time, he was packing a bag, you know, and I saw him packing the bag. I just didn't realize what he was doing. And he says, Andrew, yes, of course, you do that. I'm going Frisbee golfing with my patient right now. He was packing Frisbees into the bag. And he said, this was the best explanation of my job that I've ever heard. He said to me, our job as readjustment counselors is to show our patients that there can be life post-war, and the best way to do that is to get out and do it. And so we do the things like that. We have 4-day retreats. We have 1-day retreats, Saturday. I will tell you, it's your tax dollars at work, but it was well spent, okay? I had 46 veterans and family members Saturday up at 49 Degrees North Ski Resort, and we were snowboarding and skiing. That was a local nonprofit. The taxpayer did not pay for the skiing. All the taxpayer paid was my wages for the day. But local nonprofits that we work with paid for that and coordinated that ski trip for those veterans to get them and their family members out there active and showing them that you can be active. And it's very helpful, especially on a day like that. We have done golf groups, and it's incredible. The alternative therapies, activity therapies, all of it, just wonderful.
Yeah, I agree. I would say the way that I explain recovery to talking with a veteran that's first coming to terms with brain injury is first of all that although we have all these labels like TBI, mild TBI, moderate TBI, PTSD, chronic pain, insomnia, all these medical labels, that it's really one brain. It's all happening in your brain, and your brain may, had a physical impact to it, but it also had like a major life experience that it lived through. And so now your brain is doing the best it can, after surviving, whether it's like a recent car accident or a deployment injury. It's doing the best it can after coping with that for such a long time. And so anything that improves your brain is going to improve your experience of TBI and improve your focus and concentration. And the way that, if we have time, I have them trace their hand. They do this little healing hand of, it's like a healing turkey, like the kind you make, in grade school. And we point out, we talk about like 5 major ways, 5 major things that can help improve the brain. And we talk about it in terms of brain chemistry, that when you get a brain injury, there's the loss of chemistry there, and that translates into focus and concentration. Or if you're really depressed, that decreases it. So we're trying to add things back. And so the thumb is diet, which we've alluded to. Like if you're eating well, you're giving building blocks that make a difference and not relying on necessarily alcohol or other major stimulants. It was stimulants to stay awake or alcohol to fall asleep, but diet makes a beautiful difference, a good diet. And all these little fingers have major research behind them. The second one is sleep, which we've touched on. So just a little more sleep makes a big difference in recovery. And then Mr. Tallman here is exercise. And you touched that there is so much beautiful research supporting exercise, whether it's a severe brain injury. Frank worked with a good friend that was thrown out of a car just this past November. And anyway, she went through brain injury rehabilitation with him, and exercise movement is more powerful than so many other interventions, because the moment that you decide to move, even if it's just a short 5-minute walk, you start producing endorphins. And the moment you decide to move, you overcome an inertia that, of just wanting to stay put, or, there's all this power in decision. And anyway, the more you can get those endorphins bathing the brain, create a wonderful healing support. So exercise, sleep, and diet are 3 things that each of us have direct control over. And the 2 that a provider can order are 1, therapies, and 2, medications. I always make medications Mr. Pinky Man because really, they can make a beautiful, powerful difference, but they're like little sledgehammers. They're not specific. Like I might take Prozac and you might take Prozac, and it'll help increase some serotonin, but we don't know how it's going to affect either of us. It's highly individualized. But they have a role, but I'll tell you, the majority of everybody coming out of the service is like had enough medication. They'd please, no medication. So we just acknowledge that it's there. Thank goodness medical school exists to learn medication names. But this powerful last little finger is just the therapies that everyone's discussed. Whether it's physical therapy, speech therapy, occupational therapy, yoga. I have like a poster of your yoga group. I refer veterans, to the vet center. All these activities. Any one of these therapies, the beautiful thing about a therapeutic activity is that it's highly individualized. So unlike a medication where you have severe depression because you've survived a brain injury and you can hardly move or whatever, unlike that, a therapy it's something that you are choosing to get involved with, whether you're sitting and talking with someone or working on improving a low back pain that you've had forever, or just getting involved in a group that interests you. And because it has that component of your own self driving it, the new pathways created are healing the parts that your brain needs the most. That's highly specific to you and what you want to work on. So I'm super excited because once upon a time, when I first started working in Spokane, only certain veterans with service connection could get certain therapies. But around 2015, they broadened that to all, and then with all the improvements in the Choice Act, they're approving all sorts of things that I couldn't get for people when I started, and even broadening it more. They're finally starting to appreciate things like Tai Chi or massage therapy for the first time in the history of the VA ever. Coming this summer, will be able to be integrated as part of the the supports that make a difference. But I just want to, yeah, as far as like the best way to look at it, I think it's so important. I know that we're talking about injury and related disease or diagnoses, but it's so important just to emphasize strengths and just know that we're trying to tap into and improve any one of those. And yeah, being able to identify something that you resonate with, whether it's fly tying or a skiing group, and the VA has these beautiful recreation programs that are national level, and unless I forget to say it, it's so exciting to be a rehab doctor and help people improve a little bit here, a little bit there. But true joy, true rehabilitation is when someone is able to get back to doing something they love. That place where whatever you're doing, you lose track of time. That kind of enjoyment. That's the real highest level, and that's found in recreation. And we can have those moments of healing even amidst like an otherwise really challenging, awful, difficult life. Where we're dealing with some of the sequelae from these injuries and things. But yeah, I really appreciate what you both said. It was like just trying to keep from jumping in, but that's what I had to say there. So.
And when it comes to getting some management over a symptom that you don't like quite as much, one of the most powerful things you can have is information. So the key is you don't want to target everything. You want to choose one thing that you want to understand a little bit better, and maybe that's irritability, maybe that's sleep, maybe that's pain, maybe that's memory, and start to track how that changes over time. Because rarely is something the same always. When we're tired, when we're hungry, when we've done too many things at once, when we're around a crowd, all of those tend to affect any of those symptoms I just mentioned. So it sounds dorky, I am a psychologist, so bear with me.
Yeah.
Have a journal where you are tracking that specific behavior and noting what you're doing during the day, what you're eating during the day, what your sleep looks like if you're napping, and other things that are occurring, and see how that symptom changes. Because when you understand the correlates that make things better or worse, you can structure yourself to be successful. But very often we get so overwhelmed by the symptom and not wanting to have it that we don't want to think about it. And the trouble is that just keeps it alive. So the better we understand, and that tracking, that journaling, that understanding is the key to making a really important difference in our life. And once you've got the skill down, you can do it for one, you can do it for a lot of things, and you can start to really make a powerful difference.
I think another valuable member of the rehabilitation team is the vocational rehab counselor, thinking about ways for the veteran to be able to get back to work and have a sense of value and of that they're adding something not only to their community, but being able to hopefully begin to support their family. And this whole idea of being able to get back out into the community, live their daily life, and hopefully start to regulate some of these issues, like being able to sleep properly at night, because now you're getting out during the day and you're being active, not sleeping during the day, and so you're able to get some restful sleep at night, and really trying to get back into the community. So not only recreation, but vocation.
And I think the one thing I see is the lack of community that our veterans have once they leave service. In service, we have an entire community. Everything we have behind the gates, we have family. I mean, people we serve with are our family, essentially. When we get out of service, we tend to lose, we have our family, which is, your spouse and your children, but you lose that connective family that you would have in that community. And doing these activities that they're talking about, and these recreation things that also include their family at home, like their home nucleus, but the community and the veterans that they maybe didn't serve with, but it's still this community of people that understand where they've been, they understand what they've done, they understand some of the things that are the same or a little bit different, but you have something in common, and there's a certain sense of trust that you don't get, that I think that, we lose. As much as, our civilian counterparts, try so hard, there's just something that, we can't get for them. So I find that plugging them into that piece of community that they kind of lost helps, and that's why these organizations, helping them find other groups is important. But we also, WDVA's, their main, two of my programs were based off of ecotherapy. That theory that sitting on your couch in the dark watching TV is not going to get you better. The reality is it's only going to end bad for everybody involved. So that theory to get out off your couch, and there is, like they said, there's tons of research showing that ecotherapy is so beneficial, just getting out of the dark and coming out, and doing something positive. And if you see the table that we have over there, most all of our programs are based around ecotherapy and conservation. The one thing we lose from coming out of service is a mission. So now, my mission in service was way different than my mission out of service. But the fact of the matter is finding their new mission and what their new normal is really the key for them to be better. I mean, who would ever, my husband, the last person you would think, but the one thing that he is hypersensitive about is security. Okay, so he obviously drove a truck in the Army, so security and transportation. He's a transportation director for a school district. On the outside, he looks totally put together. Now, home is a different story. I'm kidding, he really is kind of put together. But the one thing he connects with is kids. And he connects with kids in a transportation setting because that is the most unsafe place for him. And the idea of putting his kids on the bus was something he could not think about. It is a pain in the butt to drive your kids to school every day when there's a school bus at the end of your driveway. So now he facilitates that, so it's a little bit easier. So, he connects with kids, and he was raised within the system, so he sees kids kind of at a vulnerable stage, because sometimes in a way he's vulnerable, and so do his bus drivers. So I think that it's a win-win for everybody. And it's due to a lot of these individuals and these programs that have got us to this place, because it's been a 15-year journey, I'll tell you, and it hasn't always been the smoothest. In fact, there's always going to be potholes, but it's a matter on how you come out on the other side. So
That's true. I just wanted to add that another support that has really expanded in the past few years. I'm sure you're familiar with the opioid crisis and how the nation has made all sorts of laws and restrictions to decrease opioid use. As a result of that, the VA, in trying to be more supportive of veterans with chronic pain, has approved various devices, things that we never had. You might have heard of TENS units, these basic little pads and wires to help with muscles, but there's different electrical devices right now available through therapy that can help with pain, and some of them, for some veterans, help incredibly with PTSD and sleep as well. There's something called the alpha stim that works with brain waves to try and help suppress chronic pain, but also helps us sleep, and symptoms of PTSD, anxiety, and even depression. But another one I wanted to tell you about that some of the veterans who don't like migraine medication but have horrible migraines try is a device that they call the Cephaly that just stimulates these nerves here in the face that can make a difference for some by wearing it every day in decreasing migraine. So there's a whole technical avenue of support that I just wanted to touch on that would be worth just knowing that it's there, to look at for veterans living with TBI.
All right. How we doing? Okay, I'm going to move on to another question then. What are the potential long-term challenges for veterans and service members living with a TBI? Potential long-term challenges for veterans and service members living with a TBI.
I think maintaining your speed can be a challenge. So early on, there's a lot more talk. It can be a little easier to muster some support, but then keeping that going and recognizing that for a lot of people, TBI is something that in one way or another you are managing over the course of your life, and you're constantly looking for new ways to adjust and deal with what's coming up and continue moving forward. And at different stages of our life, there are different challenges. So perhaps early on it was managing headaches and things like that, and then when you have children, it's managing noise tolerance and changes in your sleep patterns, and then changes in work. There always seems to be this whack-a-mole in terms of what you're dealing with. And so maintaining your endurance for that and staying connected to resources and recognizing that getting help at one point of your life doesn't mean that you're never going to need to seek help again. And recognizing that as new situations arise and as there are new challenges, it can be a really great time to look at assessment, look at therapies, look at plugging in and asking new questions and seeing if there isn't something else, either because technology has changed or because your needs have changed. And having somebody who can see you from a little bit different angle to work with you and your family and help make sure that everybody is doing the absolute best that they can and support whatever new learning or new adaptation the situation calls for.
Yeah. Yeah, I would definitely, I definitely agree. There's definite change over time, and the beautiful thing about our brains is that if we use them at any time in our life, there can be some improvement. That was one of the biggest, biggest discoveries. Especially, it was in a stroke population that they showed that. They used to think that once you lost a capability, it was lost forever. But there is room for improvement and exercise and adding things. And I would say with some of the veterans that I've seen, later on, may decide to revisit medication supports. Their life might be benefited by taking a stimulant medication or trying an antidepressant. Some of the medications they didn't want before, they're open to now. And the most consistent question that's come up is just, there's so much buzz. If you read about brain injury in the media, about the concern that with the studies on chronic traumatic encephalopathy with the football players and just this real fear and anxiety that's come through the door, wondering, will this happen to me? And while the evidence, for now is like, no, not likely. That study was a very particular group of people. I think it makes a difference to have support and to keep things open and just to sometimes I'll have a patient where we'll just spend an entire visit looking, just reading together what is known. And I think the most reassuring thing that can be offered is at least that we're documenting everything. Many of the younger veterans coming in just want to make sure that, look, I just want this on my chart because who knows, however many decades from now, maybe they'll find out that there's issues that we're not recognizing now. And so that kind of validation at any stage makes a big difference.
Documentation is also important because we're not going to be doing this forever. And eventually, when we leave our respective fields, that particular veteran may still need that recurring care, and our documentation will serve as a treatment legacy for that particular patient's case, so they can pick right back up where they left off or jump to where they need to jump based on where they were before, even after we're gone.
I think a lot of it too, I think in some cases is just that destigmatization. We have to take that feeling of being embarrassed or asking for help or just not wanting to talk about it, that it's okay, that, behavioral health, treatment, any of those things are things we need to talk about. And it's funny because, a family of 6, because my kids obviously have 2 veterans that served, and somebody would probably think that, we all needed help. My kids are the ones that, I've actually I have a high school student that I've had to go in and tell his teachers that we're really not all crazy because he knows more about stuff than he probably should, is just the fact that, I'm not going to pretend that it's not happening. Suicide is something that's always been talked about in our house because it's so prevalent in our work. The fact of the matter is it's prevalent in children as well. So talking about it is only going to make it, out there in the open. And so that's one thing that I think people it's funny because, you talk to some people and they're like, oh, I don't want to talk about that. And I'm like, oh, I didn't know we weren't talking about that. Like, somebody should have given me the cliff notes for this one. So sometimes my kids will have to say, I don't think they want to talk about that, how kids are, they're so honest. Or, my 9-year-old that's probably sitting out there somewhere is going to say, I didn't know that we weren't supposed to talk about that, But I think that that's the important part, is the fact that we need to talk about it. We need to talk about all of it, even the stuff that is really uncomfortable, because talking about it is going to make you live that better life and to move past it, and to be able to find other ways to manage it and to cope. And that's what I'd like to see. And I'd like to think in the last 15 years we have started talking about it. We can always talk about it more, but that's me standing on my soapbox, screaming that we need to talk about it. My kids are like, we don't want to talk about our feelings. No, I'm just kidding.
Thank you. Does anybody in the audience have a question for people on our panel? Anybody at all? Yes, sir, over here.
Thank you to the panelists who came to speak. Heather, I've met your husband. He's a big guy. I think a grunt would call him a big target.
Seth and I used to work together, or actually he hired me once.
So Dr. Perry, my question is really for you. Using her husband as a case study, someone who is in semi-professional football, has probably experienced a lot of potential concussions, head injuries, similar to someone who might have been in semi-professional boxing and has been a pugilist and has sparred a lot, and a lot of head injuries from that kind of activity. Minus the IED, other types of head injuries that happen in active duty, blunt trauma against a bulkhead on a ship, to car accidents and things like that. The stigma is the IED is really connected to the explosions for the service members. So for that service member who had a similar earlier life experience like what her husband experienced, but also had these closed head injuries that resulted in loss of consciousness greater than 30 minutes, how does that veteran communicate with their primary care team that the brain injury issue is still a significant issue, but when they're not feeling like they're necessarily getting that attention? So what would you recommend from the top-down perspective of how that veteran receives that support?
At this point, given the structure of the VA, if I was a veteran that had any concerns about head injury, regardless of where it happened, I would tell my primary care provider that I wanted to discuss what was happening with me with a rehabilitation doctor. And honestly, at this point, the veterans with brain injury are the only population at our VA that absolutely gets seen in the VA TBI clinic, which is where I work, because we've made them a priority. There's no, that way there's no, how, if the 30-day rule that's going to turn to 20-day, it's going to turn to 20 days if you can't be seen in your VA, then, we'll find someone for you. With the veterans with TBI, they're seen every time. And so it's just a matter of expressing it and asking for it. And it doesn't matter. I met with a 6-year-old veteran that was so worried about a baseball injury that he had in the 6th grade, and was just had so much fear that it was causing part of his memory and concentration difficulty. And that kind of fear and worry deserves a conversation, a protected space. So all they need to do is to speak it out loud, and it's not important. The exact history or the etiology isn't important relative to having that discussion. But it's a great question because a lot of people aren't sure what to say, since like like you were saying, the criteria that they ask in the clinic is like, did you have an injury while you were deployed, kind of a thing. So thanks for asking that.
Any other questions? Feel free, please. Yes, there's one over here, John. And then there's one in the front, I believe, too, when we're done.
What kind of guidance and direction do you give to the veterans with traumatic brain injuries or other injuries of that sort in the aspect of going back to work or limited work opportunities that are available to them in the the community?
I can tell you that at the vet center, I don't know, I can't speak for all the clinicians at the vet center, but myself, I like to push my patients. I think when it comes to doing something productive, if you can, you should. I think, and I think the panel members would agree, within their abilities at least, I think if someone has a TBI and they can, they should, and I've got the example for later that it's pretty impressive. That's what I would tell them. I would say don't be told to stay broken. Yeah, you've got some issues, but push through them and get it done.
And I would absolutely support that. What are the, I mean, we talked about little 5 things that help, but yeah, a job, even if it's not a great job, it imparts immense protective qualities. I mean, against depression, against, I mean, yeah, just against all of the sequelae, related to focus and concentration. Just having to get up and go makes a huge difference. I couldn't wait what he said. That's great.
Well, and I think for us, a lot of times, like we get contacted on the WDVA side all the time about veterans in the workplace. And one thing that we have found to be effective, if we do have veterans that are currently working, but yet they feel like their employer, if they're willing, a lot of times we've come into their place of work and we've provided them with some like education about traumatic brain injury and things that could help veterans that currently, and a lot of times they're open about the fact that they have traumatic brain injury and things that they could do to help them, be better employees. That's something that, at least on our side is really important, is that we provide the employer tools to then work with current employees and future employees that they might have as well, so that we can keep them employed. Because that is ultimately essentially the biggest thing for us, is to keep them employed and keeping their family, on that side of positive, rather than having to, come and see me for something much more grave.
And I would just add the caveat, if you can but do it wisely. So again, that service member mentality of do the mission, I'm going to do it full time, I'm going to take on everything I can. And sometimes that can set you up to fail. So it can be really helpful when you're talking about employment is to get a really good sense of how you are doing. And that can involve talking to your family, it can involve talking to doctors and therapists, maybe getting some testing done so you can identify what are your strengths. If there are things you're struggling with, what are they, and how can you use those strengths to support those? Getting the recommendations and then following them, which tends to be the hardest part. You can go in with a plan, part-time, take breaks, and then how many times do we push through them? But my vision is the goal is success and being wise about it. So get out there, do it, but do it in such a way that you're likely to be successful, because success begets success. And the more success we can get you, the more likely you are to thrive.
Thank you for adding that.
Yes.
Yeah, beautiful. I'm like,
I may have misspoke.
right, she said.
I'm sorry, I think we have one last question.
Hi, I'm a CODA student, so I have to ask about OT a little bit. With the mandate for TRICARE covering CODAs and PTAs, do you guys in the VA here in Washington find that you're moving to be able to provide more of those services, like especially with sensory modulation and sleep and cognition and all those things that, and PT is starting to talk about doing cognition as well. Do you guys find that those services are going to be made more available as well?
I'd like to think so. I mean, I don't work for federal VA, I work for state VA, but I'd love to see more. The fact of the matter is it's still, they are changing that, from 30 days to 20 days. And I don't know if that's going to be a positive or, it's hard to say yet. I think that on your side, I think you'd like to say, yes, absolutely, that'd be awesome. But the reality is getting into COT sometimes could be, you could wait.
Yeah, but not anymore.
Yeah.
I mean, it's like, yeah. So we have at least, we have, at the Spokane site, we have 2 occupational therapists and 2 CODAs, as well as a training program. Their services for veterans with brain injury have mostly been in regards to just related function and chronic pain. The cognitive component has been largely speech-language pathology, but we're looking to expand that. This just came up recently. And it's honestly just, as you know, it's a question of do you have enough people to see everyone? But yeah, with the new edict, it's like if we can't help you with the VA, then we'll reach right out. Can't tell you how much. I was one of the expert referral people for St. Luke's that I got a call when they were going through CARF certification because we rely so much on the community to fill the needs for the veterans there. But that's a great question.
Thank you. Thank you, everybody. Thank you to the panelists, and thank you for Jenny for moderating. Can we give a warm round of applause for everybody?
Thank you. Thank you, everybody.
Thank you so much for your time. My name is John Anderson. I'm the Dean for the College of Social Sciences at Eastern Washington University, and I would like to give a shout out to the team that put this together, Nick, Marissa, Elaine. I know there are others, so I apologize if I missed you. Thank you for all your hard work in putting this together. There's also their co-sponsors, the Spokane Public Library. Thank you so much for providing this beautiful venue. The Brain Energy Support Team, Eastern Washington University, and the Traumatic Brain Injury Council of Washington as well. Before we leave, I just wanted to state a couple of quick announcements. The Traumatic Brain Injury Conference will be hosted on the east side of the state, April 15th and 16th. This is the first time that this conference has been on this side of the state. So if you are interested in attending, you should find some information in your flyer or a flyer in that packet. If you need another one, go ahead and pick one up at the check-in table on your way out. Before we leave, however, I'd like to say one more thing, and that the purpose of these community events is not only to provide education, but also for you to connect. Thank you to our resource tables for being here. Please stop by. There's a lot of good information. Socialize among each other. There's some coffee, there's some tea, water, and of course, some delicious cupcakes for you there. Thank you. Have a great night. Thank you all for attending on this very chilly evening. Drive safe.
Thank you.